Okay, so guys, one thing that I just forgot to mention is that with your afferent arteriole, your afferent arteriole has got a bigger diameter compared to the efferent arteriole. When you've got a larger diameter that is supplying blood, and then on the other side you've got a smaller diameter that actually makes paves way for blood to move, it means you are going to have a lot of pressure inside here, and the blood is going to actually take time to move out of that Bowman's capsule. The reason for that is because the reason why you have a bigger diameter and a smaller diameter of the efferent arteriole is because you want that blood to spend time there. So we are delaying the process. We are making sure that that blood spends a lot of time there to make sure that you can filtrate the blood as much as possible, so that you don't have a toxic substance that arrives via the efferent arteriole into the Bowman's capsule, and then it still exits on the other side and it's not filtered out. So filtration takes time there. The blood that enters there takes a bit of time to move out, right? Okay, now let's talk about diuretics. Diuretics, as we know, these are drugs that we use for patients who are hypertensive and patients that have got edematous states like heart failure, portal hypertension, nephrotic syndrome. There's so many of them. So these are the drugs that we use just to make sure that we get rid of the excess fluid. And maybe if I can just go back, why do we use diuretics for hypertension? How does it work? How does diuretics decrease blood pressure? Remember, BP is equals to cardiac output multiplied by peripheral resistance. So mathematically, as we can see this, once you get an increase in your peripheral resistance, your blood pressure will also increase because of this formula. Or if you increase your cardiac output, your blood pressure will also increase. And also, if you decrease cardiac output, your BP will decrease. If you decrease your PR, which is peripheral resistance, your blood pressure will also decrease. Now, we know that cardiac output is a product of stroke volume multiplied by the heart rate, right? So which means if you have a drug that can slow down a patient's heart rate, that will decrease their cardiac output and eventually decrease their blood pressure. Now, what are the things that make up stroke volume? What are the things that contributes to a stroke volume? It's preload, it's contractility, it's your afterload. If you haven't watched, there's a video that I did, my very first video that I ever uploaded on YouTube, where I talk about antihypertensives. If you haven't watched that video, please do. It's gonna help you to understand antihypertensives. So stroke volume is made up of preload, contractility, and afterload. There are drugs that target contractility. There are drugs that target preload. There are drugs that target the afterload. All in the attempt to decrease cardiac output and eventually decrease blood pressure. What we're going to be talking about today is preload. The drugs that decrease preload are drugs that, remember, preload comes from venous return. And venous return is dependent on blood volume. Very important, guys, to remember this. Blood volume. Now, blood volume, the amount of blood in the circulation is dependent on the plasma or the water portion of blood. And when you have lost, so if you decrease a patient's blood volume, you will decrease their venous return, decrease their preload, decrease their stroke volume, decrease their output, and eventually decrease their BP, right? So drugs that target this pathway are diuretics, which we're going to be talking about today. Just thought I should explain that. So are diuretics. I know it's a long pathway, but like I'm saying, once you give a patient diuretics, you decrease their blood volume, and we know how do we decrease their patient's blood volume? By making them to pee, by making sure that that kidney is not reabsorbing a lot of water, is not reabsorbing a lot of water. So the more a patient goes to the bathroom to pee or to urinate, they are losing blood volume. And we know that if they lose blood volume, they will lose their venous return. Their venous return is going to decrease, preload will decrease, stroke volume will decrease, car output will decrease, and blood pressure will decrease. Right? Okay, so we're talking about diuretics. Now, when you talk about diuretics, there's a broad classification of diuretics. Diuretics are divided into two. There is a there is natriuretics, and then there's a aquaretics. Natriuretic diuretics, remember, natri refers to sodium, and uresis means to pee. So these are the drugs that makes a patient to pee sodium. Already we know that once you pee sodium, once you allow sodium once you prevent the reabsorption of sodium, then it means you're gonna have natriuresis. And once you've got natriuresis, water will follow. That's what we know. So natriuresis or natriuretic diuretics, there's what we call loop diuretics, thiazide, potassium sparing, and we've got carbonic anhydrase. We also have mannitol. Those are our natriuretic diuretics. Now, those diuretics, they act or they target specific sections of the nephron. And different parts of the nephron, they reabsorb different amounts of water. There are parts or the sections of the nephron that reabsorb more water than other sections or other parts. So if you've got a drug that works on a part that is responsible for reabsorbing a lot of water, and you've got a drug that interferes with that, then it means that drug will be much more potent than the other drugs. that act on areas that are responsible for minimum or least water absorption, right? Now, let me just remove this again. So, our natriuretics, the natriuretic that works on the collecting duct is your potassium sparing diuretics. The diuretics that work on the distal convoluted tubule are thiazide diuretics. Natriuretics that work on the thick ascending limb of Henle is your loop diuretics. Your mannitol, acetazolamide, or carbonic anhydrase, they work on the proximal convoluted tubule. That's your carbonic anhydrase and your mannitol. If you look at this, it makes sense why mannitol, acetazolamide, they are more potent than the other diuretics, because they work at a section where a lot of water is being reabsorbed. It makes sense why loop diuretics are more potent than thiazide and potassium sparing, because they work at a more proximal. With the nephron, the more proximal you are, the more water will be reabsorbed. And the more distal you are, the least water will be reabsorbed. So this is why potassium sparing diuretics, they are not so potent in terms of their diuretic action. So the next one is your thiazide. Thiazide are good for hypertension. You cannot put a patient who's got an edematous state on potassium sparing alone or thiazide alone. You need a second natriuretic, right? So thiazide are good as far as management of hypertension is concerned, and also potassium sparing. But we do know that potassium sparing are considered one of the antifailure drugs. It's safe. They are still being used, but not alone. So they need to be helped. More potent than any of these, and this one is more potent than these two, and this one is more potent than this. So because of their location in the nephron, right? Now, these drugs, as we said earlier, that they fall under the class of natriuretics. So these are natriuretic diuretics. Natriuretic diuretics. Natriuretic diuretics. And natriuretic diuretics, they prevent sodium reabsorption. Like now, what happens here, remember, we said that if we take this and zoom, this will be this side, and then we will have our apical or basolateral, apical, basolateral, apical, basolateral, then we will have this. So, going back, we've got a sodium potassium ATPase pump that takes sodium out of the cell for reabsorption. But that creates a concentration gradient. Because of that, sodium starts to going down their concentration gradient through that sodium potassium 2 chloride channel. So they start to enter. Now, loop diuretics, they prevent that sodium potassium 2 chloride channel. So what they do is this channel has got 4 locations to bind. So apparently the loop diuretics, they come in and they just bind on the chloride, and when the chloride, I'm forgetting now the name, the place where the chloride binds, the loop diuretics, they go and sit there and block it. So now they render this channel useless, and instead now of sodium entering through this channel, they don't, because it's blocked. So now you end up having sodium that actually goes all the way and forms part of the urine, which now tells us that that's what is called natriuresis. So you prevent the reabsorption of sodium, making sure that sodium forms part of the urine. So that sodium is going to go all the way, and then it forms part of the urine. So most of these diuretics, natriuretic, this is how they work. They just prevent the reabsorption of sodium. But I've explained why one class is more potent than the other. It's because of the locations. There isn't a lot of water that is being reabsorbed here and here, but there's a lot of water that is absorbed here, here and here. There is a lot of water absorbed here compared to here. So the distal convoluted tubule reabsorbs more water than the collecting ducts, and the ascending loop, because of this system, it reabsorbs more water compared to these other two. So that's the landuka behind it. So now we said that loop diuretics, they come in and they block, or they occupy that chloride location, from forgetting the proper name for this. So where chloride ions bind, that's where loop diuretics go and bind and make sure that they block the entire channel, just because they are sitting on one position, which is the chloride position. You're making sure that you don't reabsorb this, and this forms part of the urine, so it becomes excreted. Now look at potassium. Potassium also cannot enter as well, so this potassium will also form part of the urine as well. That is why loop diuretics are called potassium wasting, because if you have blocked this chloride location where it binds, it means you won't absorb potassium as well, you won't absorb sodium as well. So all of these will form part of the urine. So this is why loop diuretics are called potassium wasting. And previously, patients who are on a loop diuretic were always given potassium supplements. But the latest guidelines, they state that if a patient is on a potassium sparing diuretic and they're also on a loop diuretic, you don't have to give them potassium, number one, because this will spare the potassium. Number two, if the patient is on ACE inhibitors and on a loop diuretic, you don't have to supplement them. But you will still find a lot of patients that are still being supplemented, are given slow K tablets to take home, even though they are on an ACE inhibitor, even though they are on a potassium sparing diuretic. Okay, so guys, this is just an overview of diuretics, how they work, where they work, and maybe if we have to mention some types, I mean, obviously, the thiazide that we all know is hydrochlorothiazide. There is also chlorothiazide. There is also indapamide. Indapamide and hydrochlorothiazide are the most common thiazide diuretics that we have. And then a choice, I mean, the most common hydrochlorothiazide, indapamide, but the state uses this one. And then you also have chlorothiazide. Okay. And then you have aldactone here, or spironolactone. And here, most famous is Lasix or furosemide. There's a torsemide, but those are not, we don't have them. I've never seen them in South Africa. So the most common one is Lasix or furosemide, right? And we've mentioned mannitol and acetazolamide, the common ones. So guys, I'll leave this here. Thank you.